Welcome back to Mastering Medical. This is part 6, the final part of our renal rapid review, and we are moving from the nephron down the urinary tract. Stones, infection, tumors, and the prostate. Every pair in this video is decided by location or by exposure, and once you know which one the question is testing, the answer is immediate. Let's start with stones, because the exam loves them and they are pure pattern recognition. A patient has a staghorn calculus, alkaline urine, and recurrent infection with a urease-positive organism. Stones look like memorization, but there are only 4 questions worth asking. Does it show on X-ray? What is the urine pH? What shape is the crystal? And is there infection? 4 questions, 4 stones. Calcium oxalate is the default. About 75% of all stones radiopaque with envelope or dumbbell-shaped crystals, and it forms at any urine pH. Risk factors are hypercalciuria, hyperoxaluria, low urinary citrate, and dehydration. Note that calcium phosphate is its cousin and forms in alkaline urine, classically with distal renal tubular acidosis, which links straight back to part 5. Uric acid stones are the radiolucent ones. They do not show on plain X-ray, only on CT. They are rhomboid, and they need persistently acidic urine, so think gout and tumor lysis syndrome. Treatment is urine alkalinization. Cystine stones are the childhood ones, from autosomal recessive cystinuria, faintly radiopaque because of the sulfur, hexagonal in shape, and confirmed by a positive cyanide nitroprusside test. Struvite is the infection stone. Urease-positive organisms, Proteus classically, split urea into ammonia, which alkalinizes the urine and precipitates magnesium ammonium phosphate. The crystals are coffin lid shaped, and these are the stones that grow into a staghorn calculus, filling the renal pelvis. Struvite stones need surgical removal plus antibiotics, because you cannot sterilize the urine while the stone is still there. Now infection, and this pair is purely about location. A patient with dysuria develops fever, nausea, flank pain, and costovertebral angle tenderness. The organism may be identical. The question is whether the infection stayed in the bladder or climbed to the kidney. Cystitis is bladder mucosa. Dysuria, frequency, urgency, and suprapubic discomfort with pyuria, bacteriuria, and positive nitrites, but no fever and no flank findings. Pyelonephritis is a sending infection reaching the renal pelvis and parenchyma, so it becomes a systemic illness. Fever, chills, nausea and vomiting, flank pain, and costovertebral angle tenderness. The single most useful finding is the white cell cast, and here is why it is decisive. Casts can only form inside a renal tubule, because that is the only place with the right shape and protein matrix to mold them. So white cells alone could come from anywhere in the tract, but white cell casts prove the kidney itself is involved. Escherichia coli is the leading organism for both. 2 extras worth carrying. In pregnancy, even a symptomatic bacteriuria must be treated because it progresses to pyelonephritis and preterm labor at high rates. And if a patient with pyelonephritis is not improving after about 72 hours of appropriate antibiotics, image them because you're looking for an obstructing stone or a perinephric abscess. On to tumors. An older smoker has painless hematuria, flank pain, and polycythemia with a solid renal mass. Both of the tumors we are about to compare cause painless hematuria in a smoker. Localize first. Is this the cortex or the collecting system, a solid mass or a filling defect? Renal cell carcinoma arises from renal tubular epithelium in the cortex, usually clear cell type, and it is the paraneoplastic tumor of the kidney. It can make erythropoietin, causing polycythemia, parathyroid hormone-related peptide, causing hypercalcemia, renin causing hypertension, and ACTH causing Cushing syndrome. It invades the renal vein and can extend into the inferior vena cava, and because the left gonadal vein drains into the left renal vein, it classically causes a new left-sided varicocele that does not empty when the patient lies down. Associations include von Hippel-Lindau disease and smoking. Urothelial carcinoma of the renal pelvis arises from the transitional epithelium lining the collecting system, so on imaging you get a filling defect rather than a solid parenchymal mass. and urine cytology is positive. Risk factors are smoking, aromatic amines from dye and rubber industries, cyclophosphamide, and phenacetin. The key concept is field defect. The entire urothelium from renal pelvis to bladder has the same exposure, so these tumors are multifocal and recur, which is why patients need ongoing surveillance. Staying with the urothelium but moving down into the bladder. A patient with chronic schistosoma exposure develops painless hematuria and a keratinizing squamous cancer. Painless hematuria is the presentation for both. The exposure history decides the histology, carcinogen or chronic irritation. Urothelial carcinoma, also called transitional cell carcinoma, is far and away the most common bladder cancer in the developed world. Smoking is the dominant risk factor, followed by aromatic amines, cyclophosphamide, and phenacetin. On cystoscopy, it is typically papillary. Squamous cell carcinoma of the bladder takes a different route entirely. It requires chronic irritation, which drives squamous metaplasia of the urothelium, and metaplasia is the step that can then become dysplasia and cancer. The classic cause worldwide is schistosoma hematobium infection, and the other causes are long-term indwelling catheters and chronic stones. The histology is keratinizing squamous, so the mechanism is the point. One is a carcinogen acting directly on urothelium, and the other is chronic inflammation forcing the tissue to change type first. Painless gross hematuria in an adult always means cystoscopy, whichever one you suspect. Final pair of the series. An older patient has a hard irregular posterior prostate nodule and osteoblastic vertebral lesions. Benign prostatic hyperplasia and prostate cancer are both diseases of the aging prostate, but they occupy different real estate. Transition zone obstructs. Peripheral zone kills. Benign prostatic hyperplasia is androgen-driven growth in the transition zone, which is the tissue immediately surrounding the urethra. That location explains everything. It compresses the urethra early, so patients present with hesitancy, a weak stream, incomplete emptying, and nocturia long before anything dangerous happens. On rectal exam, the gland is smooth, symmetric, and rubbery. Treatment is alpha blockers like tamsulosin for rapid symptom relief, and 5-alpha reductase inhibitors like finasteride to shrink the gland over months. Prostate cancer arises in the peripheral zone, posteriorly, which is exactly why it is dangerous. It is nowhere near the urethra, so it causes no urinary symptoms and stays silent while it grows. On rectal exam, you feel a hard, irregular nodule. Prostate-specific antigen may be rising, and when it spreads, it goes to bone as osteoblastic metastases, classically in the lumbar spine and pelvis. So new back pain in an older man with a raised alkaline phosphatase deserves attention. Remember that peripheral zone location is also why the digital rectal exam can detect it at all, and why obstructive urinary symptoms actually argue for hyperplasia rather than cancer. Let's lock it in. A radiolucent stone in acidic urine is uric acid, while a staghorn calculus in alkaline urine with a urease-positive organism is struvite. White cell casts prove the kidney is involved because casts can only form inside a tubule. And a cortical mass with paraneoplastic syndromes is renal cell carcinoma, while a renal pelvis filling defect with positive urine cytology is urothelial carcinoma. Smoking and aromatic amines give urothelial bladder cancer, while schistosoma and chronic catheters give squamous. And in the prostate, transition zone disease obstructs early while peripheral zone cancer stays silent until it reaches bone. That completes the renal series, 6 parts and 28 confusion pairs, from the glomerulus all the way down to the prostate. The full playlist is linked below, and if this made renal click for you, the whole confusion pair library is free at masteringmedical.com. Thanks for studying with me.